And we start today with two plenary lectures. And the first one, we have the pleasure to have Professor MIGLIAVACCA from Politecnico di Milano. I spent 2 words for the introduction of Francesco. He had his PhD at Politecnico. He was director of labs from 2007 to 2018. Labs was one of the first lab in worldwide that tried to match together experimental and computational instruments and tools in the same area. He's a pioneer, his work are pioneering for the optimization of pediatric surgery procedures such as Fontan procedure, and more recently he gave a fundamental contribution for the mechanical behavior of devices such as coronary stent and for fluid structure interaction problem for cardiac valves. It's a pleasure to have here Francesco MIGLIAVACCA, and the title of his talk today is Transcatheter Valve Implantation and Thrombus Removal, an in silico perspective. Please, Francesco, you can start.
Okay, thank you. Can you hear me correctly, right?
Yes.
Okay, perfect. So good morning, good evening, good afternoon to everybody. My talk is within the personalized medicine, and in particular, I will focus my presentation, my talks on patient-specific models and digital twins area. I would start with a short introduction saying that if we want to build a patient-specific model in the cardiovascular field, there are, in my view, some essential, maybe some obvious steps, which are the elaboration of clinical images, the knowledge of data properties of biological tissues and devices, and some clinical data like temporal tracing of blood pressures and flows. And why we want to build a patient-specific model? There are manifold aims, which could be to improve diagnosis, to optimize surgical treatments, to predict long-term or immediate follow-ups, to test performance of device, or to run clinical in silico clinical trial and many others. But if I can summarize all these aims, is that patient-specific models aim in principle to tailor treatments and improve individuals' therapy. Just 2 words on the elaboration of clinical images. And here you can see a scale in space from millimeters to microns, which can roughly correspond to images that we can obtain from MRI or CT, then going down to angios, to IVUS and OCT. And we should keep in mind this scale when we have some models. And it's like when we look at the picture, at the photography. So if we use MRI or CT, we have a very blurred image. So the focus maybe is not so clear. And so we can be happy with these images, but if we go to a better resolution, as you can see, we can have a better picture. And with these slides, I want to thank the organizer of this symposium to invite me for this very good symposium and congress, which in this period, I think it's really important for us to breathe some scientific wind and to share our presentation. So thanks again for inviting me. And first I will disappoint you because I go back and I will use blurred images, so CT and MRI. So, but nonetheless, I think so again, I want to thanks for the organizer for this. So I will show you 2 examples. So to treatment, one is the treatment of aortic valve disease with the transcutaneous aortic valve implantation procedure. And the second is the treatment of acute ischemic stroke, the thrombectomy procedure. So are they connected? So there is a connection between these 2 procedures. And so the other question is if they are related to the modeling of the cardiac function. And here there is a small video, and I hope that you can hear to see which is the connection.
During a TAVR procedure, atheroma from the aortic wall, calcified aortic valve material from the TAVR catheters, and other debris can break loose and travel to the brain. Even small pieces can block blood flow to middle cerebral arteries and more distal tributaries in the brain. resulting in ischemia in the surrounding brain parenchyma, damaging millions of neurons and synapses and potentially leading to peri-procedural stroke with devastating long-term consequences.
Okay, so we have just heard that when we have calcium rupture or we have leaf thrombosis, here there are two references that you can read later on, can bring to stroke, and the necessity is to remove the thrombus that are created. So my talk is within these procedures. And I will start from the first one, so the treatment of the aortic cardiac valve disease. And what I'm showing is based on two recent publications performed by my group, and in particular by Giulio. And the transcatheter aortic valve implantation is a minimally invasive procedure which is used in the intermediate and high risk patients. And nowadays this is used also in younger patients, and is based on the stent technology, and this implantation through a catheter of the valve directly in its annular position. There are different models and devices. In the top row, you can see the FDA approved device, which are or balloon expandable or self-expandable or mechanical expandable devices. In the bottom row, there are the CE valve approved. So you can see basically they work in the similar way. So it's a stent which is expanded or expand by itself, and is anchored in the annular position of the stenotic valve. There are some adverse events, or some of these are structural aspects, like the malposition of the stent struts, atrioventricular block, which can influence the electrical system of the heart, the coronary artery occlusion, some vascular damage, or calcium that can bring also to ischemic stroke. And there are also hemodynamics adverse events like leakage, hemolysis, thrombosis, and stagnation of flow. And why we want to have a model for different reasons that I explained before, but in particular, I will show you that how we can quantify the leakage and how we can build a patient-specific workflow. And we should keep in mind that we have limited in vivo measurements, and we need the boundary condition, of course, to run our model. And the appropriate tools for this specific case, as we have the leaflets of the valve that moves within the blood flow stream, is to use a fluid structure interaction approach. How we can build a TAVI model? The ingredient are the aortic outflow tract, the calcium, and the device, so the valve. Regarding the aortic outflow tract, we started from CT imaging segmentation to reconstruct the blood volume. And then we extrude the external surface of the blood volume to create a uniform. This is due to the fact that the CT images are do not have the good resolution to detect the thickness of the aortic wall in the radial direction. And here you can see also a detail of the mesh we created. Regarding the material properties of the aortic root, we use an hyperelastic matrix with embedded fibers, both in the circumferential and longitudinal direction, based on the Ogden-Zapfel constitutive flow. And here you can see some of the parameters that we use. Leaflets. So the native leaflets were not present in the reconstruction because were not possible to detect from the CT images. So we went to the aortic root and identify some reference points on at the commissure level of the aortic root, as you can see here. And we design the valve, the leaflets in the open configuration. And then we perform a preliminary simulation to bring the valve at the end diastolic configuration, as you can see in these slides. Now we move to the calcium. So from the CT images, we can clearly detect the calcium spots. And we then linked the calcium, the 3D volume of the calcium reconstructed from the CT images directly to the leaflet, the native leaflets, as you can see in these two images. We did this for 7 patients. And you can appreciate that the volume and the position of the culture is not uniform. So each patient is different from the other. And then we can move to the valve. So this is the device, and this is a self-expandable valve, which has a nitinol, so shape memory alloy frame. Then there are the leaflets and the skirts, which are made of porcine pericardium. How we model this valve? So we started from a CAD model in a cylindrical configuration of the stents and the valve and the leaflets and the skirts, and then we deform some parts of the valve to resemble the original valve. For this specific study, we didn't have the valve to make any inspection, and we rely on literature and the information we can found on the web. But so we are quite happy about the resembling of the valve. Then we mesh the valve, as you can see in these slides, and we use a pseudoelastic material implemented in the commercial software LS-DYNA, and the data were taken from literature. This is something different from the second example I will show you, where we did some experiment to extract the material parameters. Regarding the pericardium tissue, you can see the mesh of the skirts and the leaflets, which are triangular for the skirts and quadrilateral for the leaflets. And you can see also an images of the valve from the top view. Blood, so to make FSI simulation, we need the blood, and here we use an immersed boundary method using for aortic and ventricular outlet inlet as boundary condition patient-specific pressure recorded prior the operation. And these are the details of the FSI package and algorithm that we use. And this is the LS-DYNA now ANSYS package. Results. So the preoperative situations is reported in this video, where you can see a jet-like from the valve, the stenotic valve, and here you can see that the velocity value are around 4 meters per second, which are comparable to the clinical data, the Doppler clinical data. So this is the sort of not validation, but goodness of the models in terms of the velocity present in the models. And we were able to make also a comparison with the effective orifice area calculated from FSI model, and we can see that the difference with the clinical effective orifice area taken from the Doppler measurements are, so the error difference is less than 10%. So we were quite happy about the preoperative simulation that we could reconstruct for this patient. We did this for the 7 patients, and the resemble and the matching with the Doppler measurements is quite good, with the exception of patient C. Here you can see that we have a maximum velocity of 3 meters per second against nearly 5 meters per second. And we then went back to the images, and we found and looked at the resolution in the axial, longitudinal axis for the aortic root for this patient was 3 millimeters. So this might be the cause that the model was not able to catch the geometrical structure. For the rest of the patients, so the matching is a bit better. Now, if we go to how we model the crimping and the positioning of the valve inside the aortic root, here you can see, I show you again, the crimping phase of the valve with the leaflets and the skirts. This then is positioned inside the aortic root, then a catheter is removed, and the valve self-expand, moving also. Here you can see that the calcium is pushed against the aortic root. We try to verify that the positioning of the valve was matching in some way the outcome of the clinical procedure, and this is the qualitative results. And Here it's a bit better representation of how the valve expands inside the aortic root in 4 different cross sections. You can see that in cross section 1 and 4, we have a good apposition of the stent struts to the aortic root. So we have a good anchoring of the valves. While in cross section number 2, you can see that we have an elliptical shake. So we have an ovalization of the valve, and in black, the black spots are the calcium. So this is important to evaluate, because if the cross section is not circular, we can have a not good opening or perfect opening closure of the leaflets. Here is the results from the FSI simulation. You can observe that the velocity is reduced. Now we have 2 meters per second, like in the post-operative Doppler measurement. You can see the coaptation of the leaflets, of the pericardium leaflet. And you can also observe in this area between the stents and the aortic root that there are some leakage. We quantify this leakage. So this simulation allows the quantification of the leaflet. And this is something that is not done with Doppler measurements, or in some way with the echo Doppler. It's possible to see if we have a mild or moderate or severe regurgitation, but the quantification cannot be done with a Doppler measurement. And so here I show you 2 patients that were treated with implantation, and we can see the perivalvular leakage. In particular, in patient A is a mild, and while in patient B is a bit more moderate. So we can see that we have a bit higher regurgitation. So as a conclusion of this part, so we developed a workflow where knowing and having a library of device, having patient-specific data in terms of geometry, anatomy, and boundary condition, we are able to run FSI simulation, and then we can do the consideration that, we can quantify what we are interested. And this kind of workflow, in my view, is interesting because it can be used for in silico trial. I will come back to in silico trial at the end of my presentation after the second example, and to see how we can use this kind of model. Now I will present the second example. So it's the treatment of the acute ischemic stroke with the thrombectomy procedure. And this is based on a recent accepted publication. And of course, if you are interested, then you can ask me. I can provide you all this kind of papers. And what I'm showing you is based also on the collaboration we had on a European project, which is called INSIST, so in silico clinical trial for treatment of acute ischemic stroke. What is an acute ischemic stroke? Is the occlusion of a cerebral artery, and so we don't have a perfusion of part of the brain. The clot should be removed, and if it's removed, like in this case, then we have a reperfusion of the cerebral arterial tree. Which are the treatments? So we have a pharmacological treatment, which is the thrombolysis, which is the injection of an activator in the venous system. And in this case, so the clot in some way dissolved by the drug. Another treatment is a mechanical treatment, which is the intra-arterial thrombectomy. And the clot is removed with the insertion of a stent, then is retrieved along the cerebral artery until the carotid artery. And so this is why it's called stent retrieval. Here we can see in a bit better in these, not movie, but images. We have the positioning of the guide catheter. We have the expansion of the stent in the clot. And then we have the retrieval of the stent, the clot, and the catheter until an aspiration catheter. This is the procedure. We want to make a model of this. And this is a movie of the real device that we had. So here you can see how the stent is crimped again, so can be released and crimped in a catheter. It's a very small device. And as for the valve, we have different models and devices. On the left, you can see the most used stent retriever, and these are those that we have we model. And on the right, we have other catheters so available on the market. How we can build a model? Like before, we need to build the device, so the stent retriever, the biological tissue, which is the clot, and the arterial tree. So now I start from the device. Here you can see the geometry that we reconstructed and discretized with beam elements. The reconstruction was done or with original CAD files or taking direct measurements on the device. Here you can see, for example, that with the confocal scanning microscope, we were able to measure the cross-section of the stent retriever. We were able to make some uniaxial test of the stent, and with this procedure, with this experimental data, we were able to define the parameters of the constitutive law of the shape memory alloy. And then we were able to crimp and release. So this is the simulation of crimping and release of the stent retriever. And the first things that we did, we tried to make a comparison of the experimental crimping and release of the device with the simulation. And here you can see that we can in some way catch the major features of the crimping procedure. And we did this for the 3 different devices available for our experiments. Now we move to the clot. So the clot can be different in composition. So we speak about white clot when they are reaching fibrin, and we call red clot when they are reaching red blood cells. And increasing the red blood cell content, we have a more soft clot. The data that we use are based on synthetic clot available from synthetic clot, of course, and on this literature data, and also are based on some data provided by Erasmus Medical Center in the Netherlands, who made some compression test on extracted clots. And here you can see that we have a nonlinear behavior of the stress strain curve. The first simulation that we did were inside tubes, so uniform tubes, and you can see how the simulation works. So we have the crimping of the device, and we have the release of the device, the interaction with the clot, and then the removal of the stents and the clot. And this is what you can see also in the experiments that was run. And you can see how the clot is removed by the stents. In this case, we used a red blood cell clot, so a red clot. Okay. Then, if we change the mechanical properties, or if we change the clot, we use a white clot, so reaching fibrin, a more rigid clot. Here you can see the same procedure. And when you retrieve the stents with the clot, so the clot rolls up, and the stent is not able to remove the clot. And this is what we observe also in some experiments using fibrin-rich clot. Here you can see now that the stent is trying to bring the clot, but then so we have a not successful procedure in some way. So this is the first part of the simulation that we run. Now, as before, we want to have a patient-specific model. So we need some data from the patient, and we use CT images. So, and we segment, the images were segmented, and then what the reconstructed arterial tree was meshed, as you can see in these images. We performed the reconstruction for more than 50 patients, and here you can see some details of one of the patients. And now what we want to do is a simulation of the thrombectomy procedure in one patient. So we selected one of these patients, And this is a long story, so I will start from the end. So the patient didn't receive any drugs, so there was no thrombolysis. So the patient was treated only with a mechanical thrombectomy. The clinical doctor needs 2 attempts. So the first attempt was unsuccessful, and the second attempt was successful. The difference is the positioning of the stent retriever in the arterial tree. It's very difficult to see for us, so we asked the advice of the radiologist more than one time to see what the stents was, and then he put this to white circle to say this is the end and this is the beginning of the stents. This for the first attempt. In the second attempt, again, we have the 2 markers here, and so here is the positioning of the stents. If we put together, you can see how the first attempt, the stent is in a distal position with respect to the carotid artery. Here is in a more proximal position. So the difference is just the position of the stents inside the cerebral tree. We try to do this simulation, and here you can maybe easily appreciate the position of the stents. In the first case, we have a distal position of the stents with respect to the coronary, to the carotid artery. Here, the stent is positioned inside the middle, roughly, of the clot. We run the 2 simulations. Here's the first attempt. So the first attempt, you can see the positioning and the movement of the stent inside the guide catheter. Then there is the expansion, and then there is the retrieval. You can see that the bifurcation can create some problems. So the stent this clot try to escape, but then is again taken from the stent. And at the end, so the clot is not removed until the carotid arteries. So this was not successful. The second case, when the stent is positioned in the right position as suggested by the company, those who produce the stents, we can see that the clot is removed until the final position. The true story is that we first did this second attempt. So we positioned it because we were not aware, and we positioned the stent in the right position, and we went back to the clinician, to the radiologist, say the simulation is not correct, because in the first attempt we were able to remove the stent. And then they say, no, this is not possible. So we went back, we discovered that the stent was positioned not in the right way, and then we ran again the simulation as I showed you before, and then we found that the positioning of the stent is important for the success. So this is the story. Just a few details. We use again the commercial software LS-DYNA, and the simulation. This simulation took about 1 day on with these computer facilities. So this is the situation now before, where there is the clot, and after the perfusion. The last part of my talk is okay, how we can determine if a new treatment can improve an outcome. Normally, this can be done with animal experiments or with new clinical trials. In our community, we know that in silico trial might have a big impact and can be a useful tool. And this is the reason of the project, of the INSIST project that we are running, still running, to show how an in silico trial can be have an importance. So yesterday we heard the definition of the in silico trial, so I don't go through again, you can see here. And one of the things important for the in silico trial is also that they can be used to refine, reduce, or impartial replace animal and human experimentation. The philosophy of an in silico trial is that we can start from clinical data, which can be image data or real mechanical properties, in this case from clots, build vessel geometry, a clot atlas. In some way, we can summarize this by saying that we can build a population model. From this population model, we can extract a virtual generate a virtual population which resemble real clinical data. Once we have this virtual population, we can simulate treatment like those I show you of the stent thrombectomy or also the thrombolysis. And then like a normal clinical trial, we can estimate the outcome for this virtual patient and then assemble the results like in clinical trial. So this is the philosophy of a clinical trial. So I want now to conclude saying that in silico models needs clinical images, but they are not the only data that we need. We also require fundamental biological and mechanical data and also properties of the device in case we want to simulate a treatment with devices. We need to collect patient data. We need to select the data that we want to use. It's not again just the geometry or the anatomy. We need to build, for what I shown you, a preoperative patient-specific model that reproduce the patient. Then we can simulate different surgical options, and then we can compare different options in a patient-specific way. This is the workflow that I think it's important to remind also when we want to run in silico clinical trial. So last message is regarding the future. So I think that nowadays, in the past, we use models to make a device evaluation or to optimize a device or again, a surgical treatment. Today, and I think in the next year, we are trying to use patient-specific model to evaluate the in vivo performance of a device of a treatment. And we are starting to run in silico clinical trial. What is a bit missing, or I think where we would be nice to have data and to work, is the link to biology. If we put in a two axis in a graph, so the structural integration, so the tissue level, the cell level, the molecular level, I think that the model that I show you are at the tissue organ level. And in time, they are, so in the time of hours, days, or week. Also, if we think the remodeling process that we are able to model in some of the biological tissue like the aneurysm, we don't have a small scale. I think that we need to start from what we have, from the data like wall shear stress, endothelial shear stress, and go back to a molecular level and see how this can influence the remodeling and the biological process that can again have like a loop. So want to finish. I would like to thank again Dr. Giulio Luraghi for the simulation she performed and the team I'm working on this fascinating project, and also the European project that provide us good funding, a good interaction with clinicians and other group to generate the models that I show you. Lastly, so I want you to invite to conference next July, again here in Milano, I hope in person. So soon there will be open for ABSA submission, and I hope that you will be interested also in this conference. Thanks again.
Thank you, Francesco, for this very impressive lecture. We have time for questions. You can raise your hand virtually, or in case use the chat. I don't see any. Okay, Professor Dussel, you can make your question, please.
Yes, thank you very much for this interesting talk. And my question goes to the pre-TAVI analysis. You said you measure the calcium with the CT, and I missed how this calcium data from the CT is then translated into elastic properties. Is wherever there is a CT, a calcium score, a rigid object within the aortic wall, or how do you translate calcium image into elastic properties?
So it's not a problem to have the geometry. Of course, you can see the grayscale, and so you have the volume. Then we use a very simple elastic material for the calcium, So a stiffer material compared to the aorta based on what we found on literature. There's no any say complex model which should take into account the fracture, for example, of the calcium. That would be nice, and would be also related, would be nice to make some study to see how it fractures, if it fractures, and then we have the problem may be related. This case is an elastic material, very rigid, and the radial force of the stent is not able to deform too much. So basically, it just push the calcium against the aortic wall. It's the aortic wall that deforms, but not the calcium. It's much stiffer than the, I don't remember the values, but I can provide you, so I can go back to it, but it's much stiffer.
Thank you.
Okay, we have a question from Ivan Fumagalli.
Okay. Thank you, first of all, for the interesting and very impressive talk. I have a question about, let's say, the mechanical parameters that you use in your leaflets model in the first part of the talk, let's say. And I was wondering how sensitive are your results with respect to those parameters, and if sensitivity is actually an issue as you suggested, how can you calibrate for different patients these parameters?
Okay, that's a difficult question to answer, mainly because we don't have data to characterize the native leaflets. Okay, so for this reason, we use linear elastic materials for the leaflet with constant thickness. Also, this is another parameter. And this choice may affect the preoperative simulation. So the preoperative simulation is based on the leaflets, or the original leaflets. So maybe also taking into account the fibers. I know in literature there are complex and very nice model and simulation with of the native valves take into account this aspect. But when then you implant the valve, I think this kind of say this modeling may be in some way simplified. Then, so the native leaflet don't work anymore unless they stay in a region where the stent is not opposed, and it's a simplification. We are aware of this. It's not the main focus of the study because we want to evaluate the valve. In that case, the valve is made by pericardium, and the mechanical properties are a bit more linear where they work, of course. And we have done some tests on the pericardium, and so this is a simplification. So this is what I can tell you.
Thank you very much.
Okay, thank you. We have just a couple of minutes to answer to Pasquale, who asked, is there any advantage in using mixed tetrahedral, hexahedral elements in the FSN analysis of the aortic root, or is it just a software requirement?
Okay, using tetrahedral element, it's the computation, it's a bit, you say, faster and simple. There was not a reason. As the skirts didn't affect too much the results, but the leaflets more than what we're interested in. So we use quadrilateral elements for the leaflets and tetrahedral for the skirts. The skirt is just, the function is just to avoid the leakage. So that doesn't show any mechanical properties. So this is the reason. So if you use tetrahedral, the simulation is faster. So we have done some tests and we verify that in this way. So this is the main reason. So there is no another motivation than this.
Okay, thank you very much. Thank you again, Francesco.